Uh, so I think oftentimes when we are asked that specific question, because we get asked that question a lot, I don't actually think we're being asked that question. I think we're being asked, how do you keep us safe? Because even in the hospital, I don't care whether it's meconium aspiration or a shoulder dystocia or hemorrhage or it doesn't really, high blood pressure. Let's just like talk about all of them. I've faced all of them in birth. Like any complication that you can pretty much have, I have faced just about all of them. But as midwives, like we are there, going back to like the safety aspect, like we are there to care for normal, healthy, pregnant women. I call them boring in my camp. I love boring, healthy women. They're fantastic. And boring, healthy babies. They're fantastic in my camp. So that is the umbrella of families that we serve is normal, healthy, boring families in such an endearing way. Please don't take me wrong in that regard, but they're wonderful. So our job as midwives is we are trained to not only stabilize, but we're trained to assess and stabilize moms if something starts going a little bit out of normal. So let's say that normal boring umbrella, we start to like dip our toe out of the umbrella into the abnormal realm. Or some kind of complication starts to happen. So what we do, that's why we bring all the stuff with us, is we are trained to assess and stabilize and either bring those families or that mom or that baby back under that normal boring umbrella, or we're trained to assess and stabilize and move to higher care if we need it. Like that's our whole job as midwives. And we're trained to do that. So we are trained to deal with shoulder dystocias and help get babies unstuck. We are trained to deal with hemorrhage and do fluid replacement and all of those kind of things and to keep parents safe. Like again, I said the only things we really don't have are an epidural and a C-section. So we carry IV supplies with us. We carry all the same hemorrhage meds that the hospital carries in our bags. Like we have all of them with us. We can do catheters if we need to. We have all of the things to do mom and baby vitals. We are all trained in NRP and CPR. And so if baby needs oxygen or mom needs oxygen or something like that happens, we have all of those pieces in place. We can suture. We carry lidocaine with us. So it's like our little Mary Poppins bag of magic that we come with, or 6 bags of magic that we come with. We look like little pack horses because everything that they store in the cabinets at a hospital, we just bring with us. And you don't have to travel to get to those things. We bring them to you. And so that would be my answer is like, I mean, every birth is serious to me, even if it's normal and boring because of the magnitude of what it is. It's like they all mean so much. And so I think the how do we keep us safe discussion, like we are trained to do shoulder dystocia and hemorrhage and suture and, like fluid replacement and all of those kind of things. And then if we can't stabilize and move them back under, then that's when we call in our other part of our team and take them to the hospital.
I think we've touched on, I'll put these next two questions together. I think you've already kind of covered it, so you can sort of be brief if you want. What's your policy on hospital transfers? And what happens once you get to the hospital should a transfer be necessary?
They're there if we need them. Like that's my view on it. I'm very thankful for them when we need them, whether it's the NICU team or the surgical staff or just an OB to help us. If we need something that's outside of our realm, then they're there to help us. They're willingly there to help us, and we have really good communication again. So my viewpoint is they're always on my team. I love that they're on my team because that's how I can keep my moms and babies really, really safe, is to have them on my team. And then when I get there, it looks a little bit different for everybody. So if we need an epidural and we're going in for some kind of rest or maternal exhaustion or something along those lines, then we usually go in pretty quick. We do the transfer, just like what I was saying earlier. So we do the transfer where we hand them labs and ultrasounds and your health history and all of your prenatal records and everything so that that transition is smooth as far as the medical history piece goes. And then we get mom blood draws and labs as soon as we can. So they usually will place an IV, get labs really quick. And then as far as the epidural goes, usually most moms will have an epidural within half an hour of transfer, maybe an hour, depending on whether there's an anesthesiologist in the hospital or not, and how many people are helping different clients out in the hospital. So that the epidural one is usually pretty quick. And then once mom is settled and in her realm, like we can either go and nap if she's just going to nap, or we stay there if pushing commences. So they will mandate that you continue pushing at Bozeman Deaconess if you go incomplete. So if for some reason we just can't get baby out, there won't be any rest. It'll be an epidural, and then we'll continue pushing. So it just kind of depends on the mom and what we're needing. And then as far as C-section, most of the time they will bring us in past triage, so we don't have to go into triage. And then they'll assess mom in a room, and then they'll decide if baby is okay to continue laboring for a little while, and we're gonna watch baby on the monitor, or whether we're like, we haven't seen any change in mom in 4, 5, 6 hours, whatever it is, and baby's having some trouble getting out, and so we're not seeing any change. Like, we don't know why there would be a change here over where you guys were at home. And so then we usually will make a collective decision as far as whether a cesarean is necessary. And then there's the emergent cesarean, which is incredibly rare to have, but it does happen. So if it were to ever happen, the baby wasn't doing great, cesarean's inevitable, and it's better to just get them in and get baby out safely. Then they usually will bring us past triage straight into the OR, and they'll put mom under and go in for a cesarean. So it kind of depends on what is needed as far as that goes, but we try to make it as peaceful as possible in every situation. So.
I know there's like a million different situations why you might decide to transfer to the hospital. Is there one reason that maybe is more common than others where you would say, okay, we need to go to the hospital now?
I think baby's heart rate is probably the one that I would transfer the most. Like if baby's having any kind of late decels, which tells us that they're not getting the nutrients and stuff that they need inside. So we're either seeing the variable decels where we know that there's cord involvement or some kind of lack of communication, or we've got the late decels, which they're a little more serious when we see late decels, that baby's not doing as great as they could inside. Those are probably the quicker transfers that we have if all of a sudden baby's heart rate is plummeting and we don't just have a baby flying out. That's probably the number one reason that we transfer for medical things that we find in the birth space. The other one is first-time moms. I would say we do transfer quite a bit for exhaustion. So if moms don't actually take it seriously when we say sleep and rest, like when you're in easy labor and early labor, please sleep if you can. Like lay down if you can. I don't need you sitting on a yoga ball at 1 centimeter and like working towards having this baby. Like I need you on your side, sleeping and ignoring it as long as you possibly can. Because once we hit 6 to 7 centimeters, if we've used up all of our energy reserves in the first part of labor, then the hardest part, it's the quickest, but it's the hardest part, and it calls most on mom. So that second part, if we've used all of our reserves up, we don't have anything else to pull from. And so we're kind of trying to grasp at straws. So I would say either maternal exhaustion piece, or fetal heart rate, which no one can control. Like that's why we listen to babies, because we don't know when there's going to be something wonky and hung up in there that we don't know about. That's why it's the secret place.
Just talking about heart rate. This wasn't on my list of questions, but I would love your take on it. At the hospital here, they don't offer intermittent auscultation, so intermittent monitoring. Once you arrive, you're on a monitor consistently through the entire time that you're there. When somebody is laboring with you, you do intermittent monitoring or auscultation. You listen every 30 to 40 minutes. Is that okay? Yeah, I would love to hear you talk about what you do in terms of listening to the baby.
Even though the way that we're listening to babies is different, what we're listening for is the same. So it looks, again, same thing, looks a little bit different. So as far as like the early labor piece goes, we usually let moms labor on their own in the early part of labor. Once active labor hits, that's when we're listening really close. So in active labor, we're listening about every 30 minutes to baby. And when our team gets there, we do a baseline listen of at least 10 minutes. So it's 10 to 15 minutes. We are holding a Doppler on you for 10 to 15 minutes. And we are watching what that baby's heart rate is doing in response to those contractions. So we want a good long stretch to figure out what that baseline is. And that's just the medical definition. You have to listen over a certain period of time to be able to establish a baseline. And then once we've established that baseline for that baby's heart rate, then we know that if we hear any kind of decels or variability or anything like that, we know what the baby's saying to us. If we don't listen long enough, we don't know what they're saying to us. And so we listen for a 10-minute stretch when we get there. We listen for half an hour. during that active labor time. Once we hit the phase that mom is pushing, then we listen way more frequently. So it's like once she gets to that last part of active into transition, we're upping that to every 15 minutes. And then when she starts actively, like really grunting, pushing, feeling that urge to push, we're listening about every other contraction. And we're not just listening for like 2 to 3 seconds. Like our team is actually listening through a contraction. So we will come in, we will, wherever you are, we'll like get down on your level in the birth tub, we'll put the heart rate monitor on baby. We want to listen before, during, and after that contraction to tell us whether we're having any kind of accelerations, which are really good, whether we're just at that baseline that we were talking about with good variability, whether we're having some cord involvement, which tells us a lot. So we're going to see those variables, or whether we have a late decel in the picture that we need to listen to closer. Because babies are really resilient, but they're only really resilient for a certain amount of time. So you got to catch them in that time and listen close.
In a midwifery setting as well, knowing that maybe baby is like squashing their own cord or something, you would employ like, let's get mom to move and change position, see if baby changes position and gets off that cord, and does the heart rate improve? And then if it doesn't, then okay, we've got a more serious issue here. Let's go get some medical help.
That's that listening closely.
Yeah. Do you listen for like a 20-minute, what they call a strip in the hospital?
We do the 10.
A 10,
So
okay.
We do 10 to 15 minute strip. Get a baseline.
Great.
At least 10 minutes.
Okay, 10 to 15 minute strip. And then every 30 minutes, and then you up it to every 15 minutes during transition, and then every other contraction during pushing. And do you listen more often during pushing because that's just more stressful on the baby, that period of labor?
I just want to make sure the baby's coming back up. And we can also hear head compression. So it tells us where baby is without actually doing vaginal exams. So if you actually do your due diligence listening, and mind you, after that 10-minute stretch, unless there's a reason to get a new baseline, it's only about a minute that we're listening. So we're not like 10 minutes every half an hour. Like that's a lot, unless it's indicated. But anyway, so near the end, it's really cool because you can actually hear baby's head compression. So at the end of labor, when baby actually drops down and is like laying on that pelvic floor and mom's really having that good urge to push, or she's feeling a lot more pressure, you will hear that in the contractions. And so when you're listening to that heart rate and all of a sudden you have a contraction, baby will dip with the contraction, and that's a good dip. So those are the ones you hear, they're called early decels. So those are the ones that you're dipping with your contraction, and then as the contraction eases up, that heart rate comes back up, and I'm like, ooh, bet you're feeling a lot of pressure with that one. And she's like, yeah. And that's because that head is getting squished. It's a really good response. So it's showing us that baby is getting that head squished. They are responding to that. And then once the head is released, they just come right back up to themselves. So like that is a good dip to hear in the heart rate. So like we don't want parents to be nervous about hearing any kind of dips, but that's why we listen. It gives us a lot of information without having to do like regular vaginal exams and disrupt mom at the end.
As a midwife, last question, pretty much. This has been an amazing interview. What's your policy on cervical checks? I would love to know what you have to say about that.
I hate the word policy. But anyway, I'm just kidding. I'll actually answer. Okay. So prenatally, I know that often in facilities, moms start getting checked at like 36, 37 weeks, like when they're heading up to the point of delivery. All that really tells me is that they're X number dilated centimeters and they're not in labor. And so it gives me really invaluable information. Like I can tell just sitting here that a mom's not in labor, like I can just sit with her and say that and be pretty darn confident that she's not in labor. And that's pretty much what it gives me. And so if she wants a check in prenatal meetings, then she needs to ask me for it, because I am not going to sit and just offer a check. So the only time that I really go in and do anything vaginally during prenatals is if we are at the very, very end and she wants, or we need to do some kind of induction, natural induction, then I will go in if she wants to and do a membrane stripping. But that is for the purposes of membrane stripping. We can gather all the numbers that we want to gather at that point, which tells us, it kind of gives us a baseline for her as far as where her body is. But I don't routinely do vaginal exams. And then for first-time moms, I think that it's pretty helpful in labor to go in and get a baseline for mom when we get there, because I feel like when we haven't done it before as moms, we don't really know where we are in our labor process. So unless she is really cranking and like super active and you can tell, I'll keep my hands off at that point. But if we're like Are we 5 centimeters? Are we 1 centimeter? Like, there's no need for me to call in our whole team if we're 2 centimeters. And so, if we can get a baseline that we know we're progressing normally as we go, and we can check for those first time moms, that's a good time to check. It gives us valuable information. So I only do vaginal exams when it gives us valuable, necessary information. So I would say that's one time that it gives us really valuable information. Um, Another time is if for some reason we have a mom, and I don't care whether you've had babies or not, there's some labors where it's just doesn't seem right. Like, it seems like there's something wrong. Like, you would have expected to have a baby an hour ago when you got there, and then all of a sudden there's not a baby still. And you're like, huh, like, I would have expected a baby at that point. And usually you're seeing some more indication in the labor, like a pain that's really weird or something like that. And at that point, I will look at my client and I'll say, do you mind if I just go see what's going on in there and see what's kind of got us hung up? Because I was expecting a baby a little while ago, and usually by that time, mom is very open to having something like that done. It's never done if she declines it, ever. Like, there's nothing in my camp that I will do against her will. But most of the time, it's a valuable piece of information, again, that we can gather if we go in and just see what's going on. And most of the time, it's a cervical lip or something along those lines that if we can just resolve it, we can just have a baby. And it moves things along a lot quicker. So if it gives us a valuable piece of information, then I will offer and talk about it with my client. Then we can proceed with a vaginal exam. If it is ever declined or it won't give me any kind of valuable information, I will never do it unless you request it.
I know cervical checks are typically done manually with fingers. Like, this is like 2-3 centimeters, this is 10, which is crazy to me because people have different size hands, but that's a whole other discussion. Are vaginal exams or cervical checks ever visual?
I've had quite a few moms that are really empowered that have either had babies before or they're really in tune with their body. And so I will oftentimes, even if it's not for cervical dilation, I will often have my moms check themselves in labor. So if they're starting to feel pushy, we can have mom slide her finger in and during the contraction feel how far baby's head comes down. And then when she pulls it out, I have her tell me where baby's head was. So as she's progressing, of course, she's going to be like, my whole finger was in. And then as she's feeling more pushy, she's going to be like, oh, I was only up to here. And then oh, baby's right there. And so I don't even need to put my hands in most of the time. Like, if they are wanting that empowerment of feeling baby coming down and they want that information, then I empower them to do that themselves. And there are some of my moms during pregnancy that want to check themselves. And so I tell them how to do it. And I'm like, here's the chart. Like, here's what it looks like. And so they can reach in, feel their own cervix, their partner, husband, whoever's with them, like, wash their hands. They can feel their own cervix. Like, as long as you do it clean, there's no reason that you can't be empowered to know your own body.
Final question. Yeah. What is your favorite thing about being a midwife in Bozeman?
Oh, can I give you two? Yeah. Because I feel like one is like, I've already said it. I love the people here. I love my crunchy moms. I love my empowered moms. I love my moms that like to get out and hike, and like, they're just heart of my heart. I love people making me sourdough bread and bringing me chicken eggs. Like, it makes me so happy. And like, there are people that bring me, like, they get an elk and they bring me like a roast and our whole family gets to enjoy it. Like, the heart of the people in Bozeman blesses my socks off. And I would say the other favorite part that I have is home visits here in Bozeman. Like, I am never not blessed to the richness and fullness driving out to Paradise Valley or Dillon or Whitehall or Great Falls or Livingston. Like, I am blessed all the time being able to sit in my car and live, for me, a dream, and getting to go out and sit in somebody's home and hear their heart. Like,
I can relate just with the people who come and see me in this space and work with me throughout pregnancy and into postpartum. Like, it lights my soul on fire. Like, there is nothing better. So thank you again so much for being here. Thank you for answering my slew of questions. And is there anything else that you'd like to say that you want people to know? Okay. Thanks again, and we'll definitely have you back.